Kann ich eine Zehnerschleuse haben?
You're on, Horst. We hear you.
Zehnerschleuse. Yeah. John?
Yes.
Stefan?
Yes.
Welcome back. So can we have the slides, please? This is a 46-year-old male patient. He had an embolic stroke in May this year, post-pulmonary embolism, migraine. He also had chronic occlusion of the right internal carotid artery, which was already diagnosed in 2004. That means 20 years ago when he was 25 or something like 26. EKG shows normal findings and total EKG as well, TTE as well, and the TE showed a typical PFO with short tunnel. But let's see what Bushra and Natalia, is it Natalia? Okay.
So actually, we've got the 3D image just in front of us right now. We're just looking at it. This is the left atrial view. There isn't time to do cropping, I'm afraid, so I can't make the picture look a bit more nice. But you can see the wire's already through the PFO. There's the PFO opening. We've just measured that at, I'll just do it again, actually, quickly. The opening is about 12, 13 millimeters. And you can see that there's no tunnel. The top of the fossa is here, so there's no tunnel. But there is, the septum looks a little bit aneurysmal, just to show you there, just to bring that all in. So you can see fossa ovalis, quite aneurysmal septum. The wire's bouncing around, but with the wire through, that's the measurement we got, maybe 12 millimeters. And then you can see that there's also a eustachian valve. Just see if we can get this picture better. No, we're fine. So you can see here, just looking through this picture, you can see the fossa from the right side, and there's this thing flicking around here. There's quite an extensive eustachian valve in this case as well. So pretty high-risk anatomy. And then just quickly going through the 2D, we'll start at 0 degrees, and we'll just show you can already see the wire through the tissue, and you can see the overlaps that were definitely through the PFO. And in fact, if we were to X-plane here, you would then see, hopefully, there you go, through the PFO there on the orthogonal view. I'm just moving backwards and forwards because there's a breathing artifact as well. And then we'll just do color compare, because we just haven't had a chance to do that yet. So we'll just quickly look through there, color compare. And then what we'll do is we'll move through the machine, and then we'll just go from 0, looking at the color on the septum. Obviously, we'd push up and down as well just to make sure 0, high, mid, and low. Then we're just going to look at the fossa here. Can't see anything else exciting at the moment, except for the aneurysmal septum and the PFO, which looks, other than the aneurysmal septum, the attachments of the primum septum are pretty sturdy, and they're coming to about 12 millimeters. And we'll just see if we can align ourselves up with the opening a bit better. There you can see, probably there. And there's no tunnel, as you can see as well, intermittently. I'm just going to take the color off, just so you can focus on the PFO as well. If I go back slightly, you'll see it there you go. Yeah, happy?
Okay, so let's focus a little bit details here. So those of you who are working in the structural field, they know that, but those working in coronary field only may not know this. So when I inserted the wire, I felt some resistance in at the level of the iliacs. I mean, you look at the fluoro, please. You can see that the wire is going up there easily, but then it got stuck there. So this is obviously the aspigos vein, and then you have to just pull the wire back, rotate the catheter, and usually go a little bit more medial, as you see here, and now it's going up into the IVC. And then the next was that the wire itself immediately crossed the PFO, and was ending up in the left upper or lower pulmonary vein. And then I'm currently exchanging for an Amplatz extra stiff wire, which comes here. Now we can do the measurement again with the Stefan von Bardeleben technique with the stiff wire.
But we see distinct different anatomic situations here compared to the first case, Torres. No? We have a much nicer rim. We have less excursion so far with the catheter, and I guess also with the wire, and we have a smaller base. So I hope you also consider PFO occluders now, instead of going with an ASD occluder in this case.
Let's measure the distance, Busha. I'm pushing the wire now.
So a question, Stefan. So what is the threshold for you to use the PFO versus ASD in terms of size, in terms of tunnel length, or other variables?
Yeah, we look actually, so we pre-estimated a little bit the balloon, and you've seen in the other case that actually the excursion of the membrane was pushed up more than 1 centimeter. The base was 18, which is the disc size of a normal PFO occluder. So all those are components that push you into balloon sizing and also into use of an ASD occluder in the first case. But this is totally different. I think you see a very nice rim here in the 45, 60 degree view, which will hold very nicely the disc on the right atrial side too. And as far as we've seen it from the first images, Busha was moving a little bit even into the membrane. I think this is a base of 12 millimeters, which will go very well with a standard device, I think. But we, of course, always wait for the wire, Horst, for surprises.
I'm currently pushing, and Busha, can you measure? I mean, I usually I wouldn't do all these imaging technique for routine case, but just for demonstration. And again, if you start a PFO program, my recommendation is to do TE as well as balloon sizing. But then when you have done
We're getting 14 millimeters.
13,
Yeah.
okay.
See?
It hasn't changed
So
much at all.
12,
It's
12,
quite
13
good.
was pretty close.
Okay. So now let's exchange this one here.
So, if
So
this,
we want to show you a PFO device which is not really new, but new in the European market. Is the PFO device from SMT, which is comparable to the Amplatzer device, but has a coating with platinum. I will show you the device in a second.
so with a wire dimension of 13, a 25 millimeter disc will probably prolapse into the PFO. So you have to be above that.
Okay,
So with the history of pulmonary embolism, don't know whether it's provoked or unprovoked, and now a stroke, and I'm not sure what the pathophysiology of the carotid occlusion is, but I would look for a thrombophilia, do a hypercoagulable workup in someone like this.
yeah, they did that, and they didn't find anything.
Good.
Patient could have vasculitis also causing the carotid, right? He's young, he's 40, so
I know.
atherosclerosis is a little bit less likely.
And the rate of thrombophilia is approximately 6%. We did an analysis in 500 patients, actually published this in in Caucasian.
But that's all comers.
Yeah, all comers. Yeah,
This is a
exactly.
little different with a pulmonary embolism.
But also if you
So
look
what
at
I'm
the
doing now, I want to do an angiogram of the PFO. So in order to do that, I just insert the sheath into the left atrium, for example, into the pulmonary vein. Then I insert the wire again. So I have removed the dilator. I'm now inserting the wire again. So the wire goes now into the pulmonary vein right there. And now I pull back the sheath to the level of the PFO. And where's contrast here? And I have to do a high volume injection with high speed. So we usually do 30 cc per second and 20 cc of contrast. De-airing is, of course, important. Frame rate is 7.5. Achtung, ich drehe die Röhre. I'm turning the image intensifier, be careful. Die Hand muss weg von der Brust.
So how is the angiogram going to change your decisions?
Well, in this case, not. But usually, in many cases, if I know it's just a normal PFO without any special circumstances, I would not do TE anymore. Then very often I do just by angiography. Tough? Yeah. Again? No. Again? Again?
Do you change your angulation to a cranial, slightly LAO? What's your
No.
what's your view?
No, it's,
Or do you
it's
say
LAO,
AP?
LAO 30. That's LAO 30.
LAO.
Oleocranial.
Little puff again, yeah.
Just for the audience.
Oh, but it's difficult here. Again. Again, come. Again. 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 The tunnel may be too short here. Okay, let's try it here. Okay. Inject. Oh no, it's not possible in this case. Die Hand muss raus, bitte. Kommt. So sometimes if it is more like an ASD, this was a very short tunnel, sometimes angiography does not work. Ready?
So Bushra won here in this case.
Yeah. It's not a fight.
So, Horst, are you trying to see the length of the tunnel, the purpose of angiography? What do you see typically?
Actually, when you inject, what I typically see when you inject. No, it doesn't work here. So then you see the length of the tunnel very nicely, and you also can see the diameter because the jet of the injection opens up the PFO, and we compare this balloon with balloon sizing, it's almost the same. There may be a millimeter difference or so. But in this case, it does not work because the PFO tunnel is just too short. It's more like almost like an ASD. So we will proceed under echo guidance more than under angiographic guidance here. Can I have the, okay, we didn't decide yet about the size of the PFO device. In that case, I would do a balloon sizing here. Can I have a balloon? 25 millimeter sizing balloon? 25er sizing balloon?
So, Stefan, how often do you see difference between balloon sizing and stiff wire? Or because you mentioned that you always do stiff wire, you don't balloon. Is this after experimenting with a balloon and no difference, or?
Yeah, well, we did in the beginning also, of course, balloon sizing, but I found for the tunnels or for the small sizes, it didn't really change the strategy nor the device. So it's an added part. So if you can do the procedure with 3 minutes fluoro and 10 minutes, 15 minutes, and it's a standard device, a standard size, I wouldn't go for a balloon in every case. This is the only thing. I only go for balloons in large situations and situations where I don't have a rim and that I have a very weak membrane, or in large bore situations like the first case here. I think that it was very valid to go for a balloon, like Horst demonstrated nicely, with those 18 millimeters, and then to decide what ASD device to take. I think in a regular situation, I would skip that, to be honest. But
We rarely use balloon sizing
Yeah.
anymore. It's actually the exception that I do this because we rely on angiography. So I
Yeah.
would say in 5% we do balloon sizing of regular PFOs.
yeah, okay,
And in
that's very
95
reasonable,
it's
Horst.
just,
Yeah.
angiography.
But I'm curious, of course, if you overcome the 12, 13 millimeters by Bushra now.
John, did you have another approach?
Well, for me, the utility of using a balloon is not only sizing, but to take a look if you have a long tunnel, whether it's rigid or not.
Yeah.
Because that's going to impact on your ability of, depending on what device you use,
May
of collapsing
change the
it
device, yeah.
versus having a splayed device because of a very long, rigid tunnel.
But in pediatric cardiology, I've also seen size increases by balloons that are not necessarily necessary.
So that's always the question, right? I mean, the physiology of that balloon-induced enlargement. I mean, that's to me always an open question. I don't know what it means, but.
Well, Horst is very careful about measuring pressure, which is important because there was a study from England where they aggressively detunneled by overexpanding a balloon and breaking it.
It's like making a Reshkin maneuver and then closing the bigger defect.
Yeah.
You know, it's of course gives you more impressive data on sizes, but
Yeah.
Okay, so we see here.
yeah, we see a very nice.
So that's actually smaller than what we
See?
thought, right?
Is there?
Probably, I mean, the distance between the markers is 1 centimeters. So
So
this is
there's no
definitely
flow around
smaller.
it.
No.
You have stop flow, right?
Exactly.
Can you measure?
So I think he's very close to Bushra's
In measurement of 8
1.8.
millimeters, yeah.
So even less than the wire. I
Exactly.
mean, the wire was 13.
The wire was good, wasn't it? Yeah.
So what was it?
Was 8, measured 8 here, the waist.
8. And we always have to remember it's like a coronary stenosis. We're just looking in one plane. We're having a summation image. So it can already be larger. If you would turn your C-arm, you would do multiple measurements with different angulations, etc. So one thing is the elevation.
No. So when you do balloon sizing, and this is what we tested in the early days before you were even born, there's no difference when you go LA or
That's
RO.
nice. That's nice. I'm older than you think, but it's
1.5
okay.
millimeter.
It's a compliment,
We have
Stefan.
measured here 7 millimeters only.
See?
7 millimeters. You store it?
So it supports a regular
That means we
device.
can go for the 25.
We'll see.
25.
John thinks got a small, right?
I mean, the wire
And
dimension
as
was
discussed earlier during the other case, I always go for the smallest device which can close the hole. So 25 definitely is, not more than that is needed, definitely.
That's true.
I'm reintroducing the
Yeah.
sheath now.
but a vigorous push-pull test will be
Yeah,
important here.
exactly.
Den 25er.
And adults, 18 millimeter is small.
Yeah.
So do you find yourself using 25 more often or 30 when you use PFO device?
Absolutely 25.
25, right?
Absolutely 25. I think this is 80%. Or Horst, do you agree? I think the standard device, so 30 is just an alternative. As you saw in the first case, of course, ASD occluders are also there. So I would say that the majority is 25 PFO.
99% is 25.
Yeah, very good. Yeah.
Argument just not to do anything, just put a 25, unless you have something exceptional anatomic.
That's why Horst
Yeah.
skips the echocardiography, you know. So here he was diluting his judgment a little bit, and he ended up in doing the same that he would have done without all the additional information.
So now let's look at the device. Again, this is like the
Old
Amplatzer
days,
device.
like the old days, you know.
So
That's why I like the talisman, you know. You put it out of the box, it's already
Yeah.
connected.
So the 25 millimeters is the right atrial disc?
Yes, and 18 is on the left side.
And 18, okay.
And again, the difference to the Amplatzer device, this is coated with platinum, which makes it more valuable because platinum is platinum. And I mean, it's for patients who have concerns about nickel allergy, although the Amplatzer also is not coated, but it's kind of a modified surface, so that also prevents nickel release.
But we did a systematic analysis in 300 patients. Actually, the nickel release is very short. You cannot measure it in the blood. It's just 1 or 2 days. And even patients with a nickel allergy have no problems at all. Perhaps they close even faster because they just get a local inflammation, and they had no systemic response. We did this in more than 300 patients in 2009 published, and we did measurements of the nickel blood values in the first 48 hours after the device implant, and it drops rapidly. So it's only an issue of hours, and then it's covered, and you cannot demonstrate any nickel increases in the blood levels in patients.
Yeah, this has been investigated lots of times.
Yeah.
But those who have severe nickel allergy, they don't trust in your data. So they say maybe it's still, and so on.
So it was
There's still
the
many
nickel
patients are
allergy
still
patients
concerned.
were, I think, 9 out of 300, but they had a very good
Yeah, so
outcome,
it's,
I tell you.
Yeah. Okay, so now I'm close to the septum and I look at the TE. It's now looking at TE and fluoro again. I'm pushing, pulling, it's aligned to the septum, and now this should be fine. I would release it unless Buscher tells me something differently.
It's looked really good to us. I mean, we can do a quick few checks, but I'm sure it'll all be fine.
Haben Sie Zähne? Sind die
Not
raus?
worried.
Jetzt mundweit offen.
So just really quickly, or just looking on the echo, it all looks nice. Everything's captured correctly. We can just quickly go around the degrees with a bit of color if you want us to.
So here it seems capture on the aortic rim is just really very short with the left disc, no?
Yeah, but
I think there's tension
Well,
from
you
the
mean
cable
the
in
septum
this.
secundum, yeah.
It's not a Trevisio cable, so I think there's a bit of tension, and it
this is
will
why
align.
it aligns so
It will
nicely,
align.
actually, to the anatomy. If you take a symmetric device, you typically get more gaps between the discs. So
I will center the release, so you will see that this obviously moves more than those devices which have a flexible connection.
the wire is stiffer than with the Trevisio horse, is it?
Yeah.
So
Yeah, it is,
this is
absolutely.
why it's a little bit artificial here before release. The position will change significantly with this device.
It's difficult to release it here. Let me, okay. So the technique when you mount it is mount it to the end and then do a half turn. I did that, but still it's tightly connected. So when I see that, then I advance the sheath towards the right atrial disc, pull a little bit on the cable and try again. And here you are.
And it's off.
Wow, lots of motion.
It looks, yeah, moving a lot, huh?
Is it still okay, Pusha? Yeah, I think
Looks
so.
nice.
Yeah, it's a
we're happy.
posterior membrane.
So, Horst, what do you do? You said you don't use TEE sometimes or all the time. How do you, because I noticed that you ask for specific views. So what do you do when you don't have echo?
Well, when I don't have it, then I do the angiography, so I see where the PFO is. I see the septum secundum, I see the septum primum. And then during deployment of the device, I also give contrast at the time when the left atrial disc is opened and pulled towards the PFO. Then I do an angiogram. And also after deployment of the right atrial disc, I do another angiogram.
I see. You use angiography. Okay. Okay.
Yeah. And again, important is high speed, so 30 cc per second and 20 cc volume.
So, John, what do you think? I mean, you
Okay.
think a bigger device could be more stable? I mean, what's your, no.
I think if the push-pull test showed stability, I'd be happy. You're not going to, cosmetically, maybe it wouldn't be moving as much if it was larger, but I don't think clinically there's a benefit. No one's shown that the aneurysm makes a difference on stroke rates. It's all about closing the PFO, period.
Yeah.
Yeah.
And I think in the old days when the large devices were being used, you saw more atrial fibrillation, you saw more erosion than we see in the last decade. So I think it was good to get smaller.
So it seems we have 5 more minutes before Liverpool is ready, so we could have some discussion, like questions, about this.
Have you seen any late erosion when the device is moving like this in the primum?
Oh, PFO erosions, we have seen one 20 years ago, 25 years ago, and there are, I think, 2 other reports in the literature. So erosion with PFO devices is really extremely rare. By the way, the patient with the erosion we had, that was a 25 millimeter Amplatzer PFO, and everything regarding the anatomy was normal. So let's say the left atrium was a little bit smaller than average, but not really significant difference. The septum was a little bit shorter than average, but still within range. So nothing was special there. And I remember that patient, it was a nurse, by the way, so I did my round I did the procedure on Friday, did the round on Saturday morning, said goodbye, good luck, and then I left the room and she collapsed. So that was, I will never forget that, and we did, what would you do if you have a tamponade after device closure? Question to the panelists or audience, what would you do?
So obviously, you do the pericardiocentesis, but the question, what's next, right? Because if there's an erosion, the centesis will not cure the erosion, so you're going to intervene surgically, no?
And what is the important part of pericardiocentesis? It's to retransfuse the blood, because this goes so fast, or may go so fast, that you cannot wait for blood transfusions. You have to retransfuse the blood immediately. And so it depends upon what to do then. Cardiac surgeon, would you go for cardiac surgery? directly, or what would be your decision-making when it comes to the question surgery, yes or no?
Well, if the pathology is, the question, do we know the pathology? If the pathology is rupture and erosion of the aortic root, so would it self-heal? I mean, I really haven't seen a patient, so this is all theory, right? I would assume you need surgery, but I don't know. Anybody have?
It's, we had, yeah, go ahead, sorry, go ahead.
If you don't mind, please use the microphone.
Surgery.
What concerns to me in such cases of a hypermobile septum is a late erosion of the septum primum, just behind the discs. Perhaps in such a case, I should have selected a symmetric 25-25 to give more stability, perhaps. I'm asking because you have a lot of accumulated experience between all of us, just for me to be sure that such cases are not going to have an erosion several months after.
Well, I mean, first of all, in this case here, this was the situation before I released it. So at this point, I didn't realize that there would be a lot of motion. But after release, when I saw this motion, I'm not concerned about that. I could go in with a snare and retrieve it, but I think that's not worthwhile to do, because actually the mobility of the device shows that I believe that the risk of erosion is less than when it's got stuck somewhere. So I think I am not concerned of erosion in this particular case here.
Right. So could you
but
talk
the starting point was just the overall experience with erosions in PFO, and that is very limited because so few cases have been reported. We had another patient with a different device, so that was the Astos device, even almost 30 years ago. And with that device, we had a patient who had a late erosion and was actually admitted to another hospital. They did pericardiocentesis, and then the bleeding stopped, and they did not send the patient to surgery, and he was doing fine 5 years later when I saw him again. So that means surgery is not always necessary, although very often, of course. In that particular patient, the nurse, which collapsed on my round, I did pericardiocentesis the entire night, retransfused a lot of blood, and then I sent her to surgery the next morning. So I always try to stabilize the patient, and sometimes it closes off and heals, and sometimes not. So that's my strategy in these situations.
Megan?
New topic, Megan Coylwright. I'm interested in the panel and Horst's thoughts. When you have choices, and it's a straightforward anatomy for a 25, how do we think about setting the patient up for success decades later for potential access to the left atrium? It's one reason why I try to choose the smallest device possible, so I have room in the posterior septum. But does it also influence the type of device you choose?
No. Okay, that's a good point.
Yeah.
So the smaller the device, the more likely is it that you can cross the septum. We had over the years just one patient where the septum was completely covered by a device so that we could not puncture the septum for a procedure needed later on, where we used a 25 millimeter device. That was a Gore device, but I mean, this could be any other device as well. But if that happens, that you cover the entire septum and you need access to the left atrium, and there's no space to puncture, then you can go through the device. And this has been shown with all devices. It's a little bit technically difficult, but it works quite well when you know how to do this. You have to cross with a wire or puncture, and then go with PCI balloons and dilate it up to the required diameter. So you can puncture these devices. But yes, that's another good reason to pick the smallest device which is able to close the hole. But the most important is actually when you use a bigger device. In this case here, it will be spread up. You have a big distance between the two umbrellas, and then you have flow in between. So that is the most important reason.
Yeah, but in most cases, you can often puncture posterior, and you will compress the device during the procedure, and you can go across with a sheath, and actually the system will then go back into its initial position. So we have done a number of cases where we punctured then on the posterior side of the device, and we're able to do procedures with a 22, 24, 25 French sheath next to an occluder. So it goes for smaller devices, and we've also punctured with some electricity through also Gore devices. Also, this is possible.
So we do not yet have the
So what-
ideal device, and this is one of the reasons.
Well, I mean, this is one of the reasons why many are interested in resorbable devices,
Yes.
because then all this discussion goes away. I mean, there's also always a little bit, not so much with PFO closure, but with ASD closure. But we have follow-up now of 25, 30 years, but not more than that. And we don't really know. I think we can remove the TE probe. I think we don't really know what happens with ASD occluders, which have been implanted in children 60, 70 years old later, because the anatomy of the heart obviously is changing when you get older. And my impression sometimes is that the aortic root, if it is elongated, that kind of dives into the heart, and many elderly people have a small interatrial septum. So we don't know whether this has been small from the beginning, or whether it became smaller because the aorta was diving into the heart. That's something I don't know. So I think for that reason, bioresorbable devices will be the future for this kind of procedure.
All right, so Liverpool is ready.
All right, well, thank you, Horst and team.
Thank you very much.
Very nicely done.
Thank you.